Okay.
Okay, guys, thank you for attending. I was asked to talk about how to build a pediatric electrophysiology service in general, and I would talk about my experience here in Kuwait. This is my Instagram platform, Twitter platform, or X platform, and then I also have a YouTube channel that you can uh, like access if you're interested. Okay, so really quick, my background is I did my pediatric residency at Miami Children's Hospital, which was like a 3 years duration. And then I did a cardiology fellowship at University of California, San Diego for another 3 years. And then I did EP fellowship at University of California, San Diego for a year. And then I did another EP fellowship at University of Alberta, Canada for another year. Um, and then I joined Kuwait University as a faculty member in late 2018. Uh, and and I was immediately seconded to Chest Diseases Hospital, which is the only pediatric cardiac center that offers pediatric cardiology surgeries and interventions. However, there was no pediatric EP in-house, so uh, so uh, so I felt the need for establishing, of course, pediatric EP service at Chest Diseases Hospital. So this is our hospital. Um, and before 2018, so before I joined Chest Diseases Hospital, the uh, the all pediatric and adult congenital EP cases were like not really existing. So invasive EP in pediatrics was very infrequently done, usually through visiting professors or adult EP physicians would attempt to ablate or device implant in usually kids above 8 years of age. And they might often ask for access help with our interventional cardiologists. And non-invasively, adult EP were consulted routinely for urgent matters and device checks. And um, I would, on behalf of our department, I would like to take advantage of this presentation and thank Dr. Ali and Dr. Fozia for their help throughout the years in helping the pediatric electrophysiology department or pediatric cardiology department before my prior to my prior to 2018. And difficult to treat patients were often boarded um, or medically managed uh, and or before being boarded for invasive procedures. So what I observed when I first joined, I observed that in terms of tachyarrhythmias, most were managed with medications, and dosing was often like underdosed. Medications were often underdosed, and there was high use of potent medications such as amiodarone. And I also noticed that many patients were requiring prolonged hospital stay before controlling of their tachyarrhythmias and eventually being discharged. And there was also prolonged duration of therapies as an outpatient. And in terms of bradyarrhythmias, pacing indications were not strictly um, the indication for pacing is not strictly following pediatric guidelines, especially or including post-op device implants, and uh, and but most importantly for inherited arrhythmia conditions, there was extreme gap. Very often the patients were under recognized and they were like poorly diagnosed and hence not very well managed. Perhaps there was overuse of ICD implantation. There was no genetic testing to speak of. There was not really adequate family screening. And, like specific testing such as cardiac MRI and stress tests were not routinely performed. So there is definite gap, especially in inherited arrhythmia conditions. that was immediately apparent for me when I first joined. So given the observations that I just mentioned, I had goals set in my mind. I wanted firstly to establish an EP clinic, including device checks, obviously bradytachyarrhythmia management, and especially inherited arrhythmia conditions diagnosis and management. I wanted to establish a pediatric exercise stress test because previously we used to refer the patient to adult stress test clinic, and as you might expect, they are very oriented for ischemia or segment changes, but not oriented for inherited arrhythmia conditions, as well as pediatric cardiologist. I wanted to have an inpatient EP service around, and obviously I wanted to do routine genetic testing, either locally or through private labs overseas. I also wanted to educate our pediatric cardiology team in terms of referral, diagnosis, and initial management plan. We wanted to establish protocols for SVT or JET, and then in order to educate the pediatric cardiology team, I wanted to I figured that one of the best way to educate our team, given the time limitations during the day, is to do routine EP conferences virtually, partly because of Corona and partly because it's at the comfort for, you know, of uh, of the attendees while they are at home resting and just attending the conference. Um, and then, of course, I tried to build a team, and then Dr. Abbas is attending here. Thank you, Dr. Abbas. Abbas is partly joining our team, so that's a big plus. But obviously, we need inshallah, we'll have a bigger team at some point. And then, so all these educational materials that we do usually are posted in our YouTube channel. So this is so that the our pediatric cardio staff would have always access to any material, and they can listen to it as they wish. Okay. Okay. So I did once an SVT protocol that I shared with the department. I don't know whether people are looking at it, to be honest, but at least there's a protocol and I'm taking I would like to take advantage of this opportunity to re-mention that protocol, and please have a look at it, try to follow it, and before asking me questions, or follow it, and then when I recommend anything specific, it should match that protocol. If it did not, please ask me why that is, and then usually there's a specific reason. But this is how I usually approach SVT in general, okay? And then there's a JET protocol that we also helped create. And then this is mainly for the ICU team, not for our pediatric cardiology staff team. So, we definitely recognize that there is limitations in EP knowledge among our team, and this is, international. But we did a study in which we distributed a couple of ECGs to our pediatric cardiology staff and pediatricians in general in the country, with very common and classical ECG findings that you might see in pediatrics. And we wanted to assess the knowledge of the pediatric cardiologists and pediatricians in terms of recognizing the abnormalities in these ECGs. So this was back in 2020. So we recruited 125 pediatricians and 15 pediatric cardiologists. And then we provided them with 10 electrocardiograms. And then we asked questions regarding how to best interpret that ECG. Okay. And then if you guys remember, we did, we then obviously, we got the results back, and then we analyze the report or the responses. And then among pediatricians, I mean the dark brown color is the amount of correct answers, or the percent of correct answers. As you can see, you know, for example, complete heart block was only recognized by, let's say, 18%, Supraventricular tachycardia recognized by only 64% among pediatricians, okay? Long QT syndrome and so forth. So there's definite limitation in knowledge among pediatricians, which is expected. But among pediatric cardiologists, there was also significant limitations in knowledge. For example, complete heart block was recognized by only 60% of the response, our pediatric cardiologist, and um, so forth. So WW was recognized by 80%. As segment changes were recognized by only 60% of pediatric cardiologists. Right bundle branch block was not very well recognized, and so forth. Okay, so we definitely documented the limitations, and then we wanted to, of course, improve the knowledge of our local pediatric cardiology team. So the knowledge was a little bit suboptimal, especially among pediatricians, and better but less optimal among our pediatric cardiologists. So then, obviously, we try to improve that, gap or interpret or knowledge gap by obviously doing repeated, virtual EP conferences. And I hope the knowledge is much better today compared to back in 2020. And I think it's much better. I can feel it, I can see it, but obviously there's no documentation of the improvement in knowledge, but I can feel there's much improved knowledge among our pediatric cardiology team. Anyway, so in terms of the education, this is what we did, and then we other goals that we would wanted to establish is to guide our surgeons on how to implant leads when there is an epicardial implant. Okay, so we went to the OR. We obviously do intraoperative lead checks. We guide the surgeons where to best place the lead. We guide them what devices you should implant, whether single chamber, dual chamber, cardiac resynchronization therapy, and so forth. Okay. More recently, we are guiding them or recommending placement of the ventricle leads all the way to the left ventricle or the systemic ventricle. That usually results in better synchronization and better function. Okay. In terms of EP, invasive EP, we did have routine workshops, and we select complex cases for the workshops so that we have the best results possible, and we learn and gain experience from those complex cases. So we did regular, routine workshops roughly twice a year. And then we thank all the experts that came to us from Qatar, from Oman, from the USA, from UK, from Spain, and so forth. Okay, and then again we thank our adult EP that are very valuable and very supportive whenever we need them. We in general do routine invasive EP studies and ablation, and then we use 3D systems that allow us to do EP studies with zero fluoroscopy, often, very often, most of the times, so that we protect the patients and ourselves from X-ray radiation. Okay, so we also since we joined, we wanted to establish databases, and so that we know how are we performing and how should we improve. Okay, so that database started in 2019, beginning of 2019, and we registered all our EP studies and ablations into that database. So far we did around 180 now cases, and with a success rate of 94% for non-congenital heart disease patients. Okay, just normal hearts with arrhythmia, often SVT. Okay, so we had a 94% success rate, and then we had 10% recurrence rate for pediatric patients with congenital heart disease. The success rate obviously is less good, down to 83%, with a recurrence rate of 17%. Okay. And then for adult congenital heart disease patients, the success rate was around 75%, with a recurrence rate of 12.5%. Okay. Like we said, we often do minimal or zero fluoro radiation. We often do not even wear lead because we don't use radiation. And this was the first time done in Kuwait through our department. So it was never done in Kuwait. We started at zero radiation, protocol. And now our adult colleagues are slowly also doing zero radiation or zero fluoroscopy cases, uh, but less routinely compared to us. Okay, so we did influence adult EP colleagues, and I think this is for the best of them and for their patients as well. We had minimal complications, but mainly in the adult congenital heart disease group. But if we compare our results to like a large pediatric cardiac center, like for example, in Boston Children's Hospital, they also had for non-congenital heart disease patients, they had like 92% success rate, or for AVNRTs and 97% success rate for accessory pathways, and tachycardia is 89% success rate, so roughly the same as ours. And they had for patients with congenital heart disease, they had 81% success rate, roughly the same as ours. So we are proud we're proud that our results matches almost one of the best centers in the world. But this is obviously it's a team effort, okay? So I think our results when we speak to our patients, we let them know that our results are equivalent to major cardiac centers around the world. So they feel more comfortable when we mention our results. Anyways, so as part of because I'm faculty staff in Kuwait University, I always try to also be academic and publish papers. So we wrote about AFib in congenital heart disease patients. We just recently wrote atrial flutter chapter, but that is pending publication in practical pediatric and congenital electrophysiology textbook. And then we also submitted recently a paper with collaboration with other centers around the world in terms of mid-septal or high risk accessory pathways ablation in children. So for devices, our routine is to recommend epicardial placement of devices if the patient is less than 20 kilograms. But we implant routinely loop implantations like subcutaneous devices, and we do implant pacemakers, but often for above 20 kilogram patients transvenously. And then most recently, we're doing left bundle pacing, meaning we're trying to engage the left bundle when the pacemaker is stimulating the ventricle, so that we're pacing as if we're pacing the systemic ventricle. And like we said, this usually results in better synchronization. Okay, and that's one example of a recent left bundle pacing implant that we did. And as you can see, let me just try to show you. As you can see, the QRS is very narrow. Okay, so there's a pacing spike followed by QRS that's very narrow. Okay, so the narrower the QRS, this usually means that the synchronization of the ventricles are much better, and hence the function would be better compared to a paced QRS that's very wide. Okay, that's the X-ray of the patient. So the ventricle lead goes down the SVC, and then all the way to the septum, perforates it into the left part of the septum. Okay, often the lead goes all the way down to the RV apex, like this, okay? But more recently, we're trying to perforate the septum into the left ventricle, or like not total perforation, but we're trying to perforate the septum so that it engages the left bundles, the left bundle on the of the septum. Okay, makes sense, guys? Okay, and that's the atrial lead, obviously. Okay, um, and then we firstly did left bundle pacing with guidance from Dr. Enes from Turkey, and now we will routinely do them in pediatrics going forward. Okay, locally here. This is of note, this left bundle pacing is only recently being done, like in the past 5 years in adults. So us and pediatrics were slowly attempting to do left bundle pacing in pediatric patients as well. Okay, so there's a learning curve, but we're happy that we started that learning curve, and so far we had no issues with left bundle pacing. And then obviously ICD implantations we are also done, and we including subcutaneous ICDs, which are usually larger devices, but usually in adult congenital patients because they are adults. And most recently, we did a subcutaneous ICD implant in a adult congenital patient with dextrocardia. Okay, and then but otherwise transvenous ICD pacing is routinely done. Like for example here, so this is the lead, an example of lead that goes down to the RV. Like this routine placement of the RV lead. But like we said, if you wanna better synchronization, left bundle pacing is usually would result in much better synchronization. Okay, but this is not done for ICD devices, only for pacemakers. Okay, questions, guys? Make sense so far?
Yes.
Okay. Insane. So again, for academia, we published our outcomes for pacemaker implantation post congenital heart disease surgical repair. We posted our outcomes for isolated congenital heart blocks in pediatrics, like locally, and we also collaborated with other groups in terms of like swelling over cardiac implanted devices and so forth. Okay. So for inherited arrhythmia conditions, we also, like we said, there was a very big gap in diagnosing such patients. So we established that database again, January 2019. And briefly, we had so those conditions are subdivided into channelopathies or cardiomyopathies. Okay. For channelopathies, obviously, the most common channelopathy is long QT syndrome. And then we have roughly 21 families with long QT syndrome, okay? And then we have other families with other channelopathies, but long QT syndrome obviously is the most common, okay? And then for cardiomyopathies, we have, good number of patients with arrhythmogenic cardiomyopathies, and so forth, okay? So, so for long QT specifically, the prevalence is like 1 in 2,000, like this is in the Western world, okay? But here in our countries, I think it's much more, it's more common than 1 in 2,000, maybe 1 in 1,000, in 1,500. And then FYI, it's more common than, for example, cystic fibrosis, nephrotic syndromes, and so forth. And obviously, most people would know how to, study nephrotic syndrome, the cystic fibrosis, and so forth. But long QT syndrome is not very well recognized and not very well taught, despite being relatively prevalent. Okay, so this long QT syndrome is unfortunately often missed because there's less teaching and recognition of that disease. Okay, so hopefully with time we try to educate the physicians about long QT syndrome, so that's best is better diagnosed. Okay, okay. And then we had a couple of inherited arrhythmia conditions that deserve publications, and we have just we just submitted a paper that is under review regarding one of the cardiomyopathies that is rare that we encountered recently. But in general, whenever we encounter an interesting case or family or disease, we try to publish it and share our knowledge. Okay. Okay. So now going forward to 2024, we are now doing once a week EP clinic. We're doing once a month exercise stress test clinic in Hisham Sagar. And then for genetic testing, we we thankfully attracted one of the geneticists into cardiology or cardiac genetics. Her name is Dr. Buthaina. So uh, we would like to thank her for helping us diagnosing our cardiac genetic disorders. So we always refer our patients to Dr. Buthaina, and she thankfully fast forward the testing so that the results come back relatively soon. Otherwise, we can send our like specimens to labs in the US or Germany. Obviously, not for free, but the results are usually they come back within 3 weeks, so much more faster than locally. So this is an option that we present to patients if they are willing to pay the fees. And also we collaborate with Duke University, specifically Dr. Andrew, that for any patient that we cannot find an etiology genetically, and we think there's a genetic disease, but there is no the genetic testing comes back negative, we send the specimens of such families to Dr. Andrew, and he and his research team try to figure out if there's a genetic mutation among the family that explains the phenotype. So we already did send him a couple of patients, and it takes a while, of course, and he may never find an etiology, but if he did, it would be very nice because then we have an explanation of why the family is having a specific disease, and then we better screen the rest of the family members. Okay. And then in return, I usually give routinely Duke University EP conferences so that there is a collaboration between us and Duke University. Okay, and then more recently, we established collaboration in terms of MRI assessment and interpretation with Dr. Pablo Garcia in Madrid, but obviously for fees. And then we do EP, procedure roughly once a week. Sometimes we need to do fleck challenge testing for like Brugada patients. And then we do, of course, routine conferences as a speaker and attendee. And then I join multiple EP groups for my personal education and to share my knowledge with others through WhatsApp groups, Twitter, and there are foundations and organizations that I'm part of. Okay. And I learned a lot from joining such organizations and being on platforms such as Twitter and WhatsApp groups. I learn a lot from other experts in the field, local, like in the region and internationally. So, in order to establish a specific, program or a specific department, you really want to have good relationships in general with your departmental heads, ministry officials, and in my case, obviously adult EP where help and support is invaluable. You need to reach out to experts in the field for support and guidance. Like we said, build a regional community so that you have a quick, like quick opinions or second opinions, like when you encounter a difficult patient. For example, I am part of Gulf EP group, and there's also African EP group that I am part of, and we can exchange knowledge and ask questions to each other and get responses relatively quick. Obviously, like we said, I have multiple friends like in the US and Canada and so forth, and I routinely send emails to them and I get feedback from them. And they enjoy our cases because they're usually unique, and I enjoy their opinions because they are very valuable and they are very experienced individuals. And it's nice as you establish a specific department. It's good to not forget, try to do some research, and present your outcomes and participate at conferences as a speaker or attendee so that you are up to date and get to know, people. Obviously there are challenges. For example, you have to cover, because I'm the only one in the country, I'm covering 24/7 even when I'm traveling. I don't have like a more senior mentor, but like we said, nowadays with WhatsApp, with phone calls, with emails, with Twitter and so forth, things are much easier. And local challenge here is that we don't have electronic medical records, so like studying patients and obtaining information is a little bit more difficult, unfortunately. And then for us in EP, or specifically for inherited arrhythmia conditions, we very often need DNA samples to perform genetic testing. And if we have a deceased patient or someone who passed away, we often hear we don't save tissue specimens so that we in the future do genetic testing. And then we encounter many families that refuse to do genetic testing, or are not compliant with medications, or are not do not come to clinic visits routinely, and so forth. Okay, so obviously, in order to be successful in establishing, like a specific department or field, you want to work hard, of course. You want to, travel, study in good centers where you gain experience. And these are like just some pictures of from Miami, from San Diego, and from Canada. And then with such knowledge with such experience and such knowledge, confidence comes in, and then you better perform when you get to see patients. Really quick, in the adult EP world in Kuwait, obviously they are doing all what we mentioned, plus they are doing stuff that we don't do in pediatrics. So there's now leadless devices, there's extravascular ICD, which is very new. So they place the ICD lead under the sternum. And this is not yet approved for pediatrics. It's to avoid transvenous ICD implantation. And the device is usually smaller than subcutaneous device. They do more routinely transvenous cardiac resynchronization therapies, and they do left atrial appendage closure, and they do now, pulse field, so PFA for AFib ablation, which is like a newer type of ablation procedure. And then they do also epicardial ablation that we don't do routinely in pediatrics. So there is also in the adult world, there's the EP services that are provided here in Kuwait is like the state of the art. Just FYI, I'm not an adult EP, so just I wanted to just recognize the adult EP, my adult EP colleagues here in Kuwait. Anyway, so in conclusion, طبعا try to start, you should be a safe doctor. You should have knowledge, experience, confidence, and start good, and then slowly increase and raise the bar. Okay, and then don't forget to be kind to yourself, and take care of yourself, because and avoid burning out, because when you take care of yourself, then you can perform for many years to come, and this is best for yourself, for your patients, and so forth, and for your department. And then lastly, we do have an Arabic platform that we educate our non-English speaking patients, and they can easily approach us and ask us questions through Instagram, our Instagram channel. Okay, and then I would like to thank Dr. Adnan. When he was when I first came in, he was the department head, and then now Dr. Mustafa as our department head. I would like to thank all the cardiology staff, especially those that are attending today, Mitwalli and others. I would like to, like we said, ICU team, and our nurses and technicians, and secretaries and everyone. Without them, our results will not be as good. Okay, and I should not forget anesthesia people as well. Okay, thank you.
شكرا دكتور محمد.
لا.
شكرا
شكرا دكتور محمد.